Please start the video.
Very good evening, everyone.
Welcome to Merrill Endosurgery, your one-stop surgical solution empowering excellence across oncology, bariatric, thoracic, gynecology, urology, gastroenterology with innovative and reliable instruments. From precision cutting tools to advanced energy devices, we deliver comprehensive solutions for modern surgical needs, ensuring safety, efficiency, and superior patient outcomes. Introducing Mirus, range of stapling products. Powered endoscopic linear cutter. Endoscopic linear cutter. Linear stapler. Linear cutter. Circular stapler. Hemorrhoid stapler. Monic trocars. Eliaro trocars. Eliaro bladeless trocars. Mesic energy device. Mesic compact ultrasonic. Mesic ultrasonic. At Merrill, we don't just innovate, we empower. Together, let's create more to life.
So good evening, everyone. I welcome on behalf of Amasi you all for yet another session of Amasi Lens, where on every third Thursday we some of the eminent faculty shows live surgery or a live minimal edited video, and emphasizing on tips and tricks of that procedure. And for this time we have none other than Dr. Subramanyeshwar Rao, who was a past president of Indian Association of Surgical Oncology, a teacher to many of us, and once you hear him, you'll get to know much more about the procedure. Today he is going to show about thoraco-laparoscopic esophagectomy. Welcome you, sir. For to moderate the session, we have two eminent moderators, Dr. Sandeep Sabnis, who is EC member of Amasi, and a GI surgeon who does a lot of bariatric as well as esophagus. He is from Nasik. And second moderator is Dr. Karthik, who's a consultant at Tata Memorial Hospital in the thoracic unit. So just wanted to have a glimpse of a GI as well as thoracic surgeon, and I think they also will learn from Subramanyeshwar Rao sir. So I'll hand over the mic to Dr. Moderators for the future for the proceedings. Over to you, Sandeep and Karthik.
Good evening, Rao sir. Good evening, Regi sir. We are actually honored to be here and got an opportunity to moderate your session. And actually, we are also learning from your techniques. So I think Dr. Karthik wanted to say something.
Yeah, that's what we will also be an eager audience to see what Sir has already taught. He's going to re-emphasize again in the video. Thanks to Amasi and Samir sir for this opportunity.
I think let sir show the video, and please generate some discussion so that newcomers or beginners or maybe even the experts would get further tips so that our patient safety is emphasized. I think Dr. Jani is here. Dr. Jani is president of Amasi. Welcome, sir. I think he can't hear us. Jani, sir?
Oh, hi, good evening. Please carry on. Yeah. Please carry on. I think we are.
Good evening.
Am I audible?
Good evening, Jani sir.
Good evening.
Hello.
Good to see you. Actually, I was waiting to see you.
Sir, you can start the video, sir. Your presentation. Yeah.
Good evening. I'm not sure if I'm audible or not.
Yes, sir. Sir, you're audible.
Yeah.
Yes, sir.
Yes, sir. You are very
Am I audible? Right. Good evening, Dr. Rao, and we are all the moderators. We have been waiting for the talk since long. It postponed a couple of times. So I think without wasting any more time, let us jump right into it.
Thank you very much, Kalpesh. I think the initiation of my presence, possible presence in this Amasi lens, much popular Amasi lens is because I met Kalpesh in Mumbai. For some time, we were sitting next to each other, and I deeply thank him for remembering me all the time. So it's been great friendship for a very long time. We are mutual admirers. And then Samir, of course, I've known him for a long time. He has been persisting. He has been calling. I really thank him for being a good friend for a long time. Sandeep and Karthik, I'm actually new to this module of presentations. Most of the time, I've always believed that each slide should have a 45-second video which carries a strong message. But Amasi has always been in the forefront with leadership of Kalpesh, Samir, and others to generate different formats for learning. And this is a very good format because you are just seeing one patient's video and what the surgeon actually goes through. So I would request the moderators to stop me in between if there is anything that they can add. If they have a specific experience in any particular area, and then Kalpesh and Samir, of course, you can always chip in. These are 15 minutes single video of a patient, and that's what I am heading this great institution, a 670 bed cancer care facility, doing about 700 procedures per month. 55-year-old male, squamous cell carcinoma, lower third esophagus, received cross protocol radiation therapy. That's what we do for all squamous cell carcinomas. You can actually see a lower third lesion there, rest of the abdomen is normal. The operative plan would be staging laparoscopy first. Many of you would be surprised, why would you need to do a staging laparoscopy if you are actually planning a McKeown's esophagectomy? The reason is there were situations when we completed the thoracoscopy, and when we came into the abdomen, we actually found peritoneal disease or a very grossly involved stomach, making the procedure much more difficult. So we do a 3-port staging laparoscopy to assess how the fundus is, and for a lower third, it's much more important to see whether the upper part of the stomach, fundus, G-junction are involved. So that's what we have done. And then at the same time, what we do is we do an ultrasound of the groin and inject 1 cc of ICG, 2.5 milligrams of ICG under ultrasound guidance. And also do a aerosolized ICG. We nebulize 3 cc of ICG, that is about 7.5 milligrams of ICG into the tracheobronchial tree. Patient position is semi-prone. These are the 5 ports that we use because we do an extended 2-field lymphadenectomy for all patients, all squamous cell carcinomas and many adenocarcinomas. The first port is the 5th space entry at the tip of the scapula, a little below, about an inch below the tip of the scapula. We prefer an optical trocar because if there are adhesions, you can actually see it much better. And then under its guidance, we do the other trocars. We always inject xylocaine to block the nerve. And then while the trocar comes in, it comes in exactly in the center of the intercostal space so that there will be no bleeding or no nerve injury or no paresthesia. Once we have done this, all roots are in. We started the inferior pulmonary ligament unless the patient has a middle third tumor which demands a trial dissection upfront. So if that doesn't happen, this is probably the best thing to do because if you are not doing a double lumen intubation, I think it's good to cut this so that the lung drops away and then stays in the chest without actually disturbing your field. And then you continue the pleuropulmonary cuts. you can go very close to the lung if you need it, especially if it is locally advanced. And after chemo radiation or chemotherapy, if it doesn't respond well enough, it all depends on how much margin you would need and the site of the tumor. You have two facial planes here, which are very important. And if you have a tumor that is abutting the pericardium, it's always good to take one of these layers off with the esophagus. There can be a small opening in the pericardium sometimes, but that would not hurt much. If it is a large opening, I think it's good to repair it or patch it to avoid herniations of the heart, which are rare, but it can happen. So those are the two layers that I was talking about. So you choose the layer as per the tumor. And then you climb upwards onto the carina. And what is important here is to cut only the pleura. As we achieve much higher PCR rates, what becomes important in today's esophageal surgery, especially post-chemo radiation, is to cut the pleura beyond the vagus nerve, because to vagus to the bronchus is always desirably preserved. You can more often than not, we see surgeons going very close to the bronchus and cutting the pleura. That is when the vagus is lost. We need to understand that the commonest morbidity of esophagectomy is 40%, and the commonest cause of non-surgical mortality is also the pulmonary morbidity. So to decrease that, it's important to at every step to preserve nerves and the blood supply. And when I'm talking about blood supply, what appears there is a vessel that is being frequently reported these days, a communicating vessel, a vessel, a significant vessel which is running from the right side to the left side. I'll show it in greater detail later on. The pleural cuts can be completed dorsally also. Many surgeons complete the ventral aspect and then go to the dorsum, but that's something that can be done depending on situation and the surgeon's choice.
Rao sir, I have a question. So
Yeah.
do you routinely use capnothorax?
Yes. When I'm doing a robotic, we have much lesser experience than in thoracoscopy. We do a double lumen intubation and we don't use capnothorax. But if you are doing the thoracoscopy, it's all single lumen, semi-prone position, so we use capnothorax at 10.
Okay.
Yes.
The only the capnothorax slightly also helps pushing the diaphragm down, so dissection in the hiatus becomes slightly easier.
You also use Karthik?
Yes, sir.
Yeah, because I think it's good to use, and at 10 it doesn't harm the patient at all and or trouble the anesthetist.
How much pressure, sir, you maintain?
10. We use it at anywhere between 8 and 10. 10
Yes.
generally. Yeah.
Yes.
You won't need it at 12, unlike in the abdomen.
Okay.
8 is good enough. 10 is all right.
And any preference of energy source?
I'm practically a ligature surgeon.
Okay.
I use the harmonic also.
Okay.
Both.
Sandeep?
But if I have to use a single instrument, then it is ligature.
Okay.
Yes, I do agree with both of you, sir. We also had a similar protocol of using 10 to 8 to 10 millimeter of mercury.
Yeah.
One thing for the benefit of a younger crowd I wanted to ask you is, irrespective of the histopathology of the tumor, do you always follow a diagnostic laparoscopy?
Yes.
Squamous, which we're doing in this case. So
yes, because
lower third, yes.
Upper third we don't operate. Middle third and lower third.
Yes.
Sandeep, we had our bad experiences.
Yes, I agree, sir. I do agree with the.
Even one experience can really knock you off, because you mobilize the entire esophagus for about 2 hours, 1 hour, 2 hours, 3 hours, and then you come down and suddenly understand that it is either incurable or
Yeah,
it's very difficult to do a pull-up.
Yeah.
And if you have to do a colon in such situations, I think it's not appropriate, isn't it?
Perfectly agree, sir. Completely agree with you.
It takes 5 minutes, and you use the same ports for the for the laparoscopic mobilization of the stomach later on.
Stomach as well. Yes.
Yeah, but the only thing is the patient goes onto the lateral position and all that. It takes a little longer time, but I think it's worth it.
It's worth it. Yes.
Safety is much more important than the duration. Yeah. Continue to make the cuts, and generally the thoracic duct, we have injected ICG. Thoracic duct is generally seen as soon as you go in, but this patient has a left-sided esophagus, so especially the middle part or just around the subcarina, the thoracic duct actually dips inside, and you may not actually see even in the best visual system. So it's important to cut the pleura, and that is when you see the thoracic duct. With technology, I think this preservation or sacrifice in a very planned way is becoming much more easier these days. And I don't sacrifice thoracic duct by principle. We do it by necessity, and that necessity I've always understood. We have been reviewing videos is not because there are lymph nodes there, but that necessity is because the primary can creep onto it and then involve it. So, which is not very common, but it can happen. We keep doing salvage esophagectomies. I'll show you a short clip of salvage later on. But in those situations, I think a thoracic duct may need to be clipped, or you may need to dissect very close. For the sake of lymphadenectomy, thoracic duct is practically never necessary. Over about 500 videos, we have never seen a node which is adherent to the duct. And what is important, what I would want to stress is to clear this part, the number 110 lymph node, the diaphragmatic crus. Nodes at the diaphragmatic crus are very important, especially in lower third. Even in middle third, you keep seeing these nodes being positive. At the hiatus, generally there is a tendency to stay too close to the hiatus. It's important to go a little lateral and then clear 110 very carefully, because that can be positive and that can be left behind. You would have done a very good thoracoscopic esophagectomy, but you would have left behind the most important node, not because you are not skilled enough, but you don't understand that there can be multiple nodes there. They're very consistent, especially on the right side, and they need to be removed.
Sir, sorry to interrupt you.
Yeah.
Can we have a full screen view, sir? Can you make your screen full?
That is a full screen, actually.
Oh, that's the maximum. Okay.
That
Okay.
is
Sir.
maximum. I'm seeing the full screen. I'm surprised.
Subramanian sir, do you follow the concept of circumferential resection margin while mobilizing?
Yeah, anybody would follow, is it not? So we don't do radical esophagectomies after the chemorads protocol,
Yes.
but CRM becomes very important.
Yeah.
And after chemoradiation therapy, CRM being positive is not very common.
Yes, absolutely right. So we follow a template
correct.
in the esophagus after the neoadjuvant therapy.
What do you all do with neoadjuvant chemotherapy or radiation therapy?
So, sir, at present, a trial is going on comparing both.
Yeah.
But in general, for purely middle third and lower third, we follow neoadjuvant chemoradiation.
Okay.
The growth goes to the G junction, or there are superior mediastinal nodes.
Mhm.
We prefer to give neoadjuvant chemotherapy when the radiation field is too long.
Yeah. I think that's a good strategy. We do for all squamous at present neoadjuvant chemoradiation, even if it is lower third, flot chemotherapy for adenocarcinomas. So that simplifies the protocol.
I think close to 90% of esophagus come in locally advanced. So
Correct.
neoadjuvant therapy is mandatory.
Mandatory. So I would say, symptomatic esophageal cancer is never early esophageal cancer, is it not?
Yes, sir.
So that is the experience. Patient with dysphagia will always have a stage 3 or a stage 4 cancer. See, I was swaying close to the esophagus here. I thought that is pleura, but then understood that it's a lymph node. So there are lymph nodes here. For fear of opening the pleura, we should not leave behind lymph nodes. And generally, especially in smokers, the pleura, the lung and the pleural reflection, it looks black in color. So the anthropotic node can be missed. So it's important. Even if you open the contralateral pleura at a certain time, it would not really matter. But it's very important to clear the lymph node. So secondarily, I have done that and then sent it separately, and this particular node was actually positive. So it's important to get all the nodes out. And this component of the video shows you that there is the vagus running into the trachea.
Yeah.
It always comes like a bowstring and then comes down onto the carinal nodes. So this makes it difficult to clear the carina, but I think it's important to spend some time here. For me, it's about half an hour clearing the carina because I'm very conscious about both the right bronchial arteries, left bronchial arteries, the vagus nerves of both the bronchi. We've clearly understood that the patient's pulmonary morbidity decreases significantly. You can actually see the bronchial artery there, red bronchial artery,
Beautifully seen, sir.
communicating there. So it actually passes through, and you'll be surprised. I have at least 20 odd videos showing the communicator. I've spoken about this in Edinburgh last year, and we have shown these videos of carefully preserving this vessel and doing an ICG to show that it actually perfuses the bronchus.
Excellent dissection.
Need to dissect all around carefully, steadily, and that is a vessel. And please believe me that it is not uncommon at all. See, if you start at the bronchus and then keep cutting, you will never find it because it comes off in the packet of the carinal subcarinal nodes. But if you look for it, you will see this in at least 2 out of 10 patients. Small communicator, big communicator, sometimes that is the only vessel that is there. There can be a right bronchial that is absent when you have this communicator. So there's no use preserving the azygos when you have lost this vessel because that patient would not have a right bronchial anyway. You would have taken all the pains to do a good lymphadenectomy while keeping the azygos, but you would have actually lost the only bronchial that is there running on the carina like this patient. You can actually see that there is a tweak that is passing upwards into the node, which may need to be sacrificed later on. That is the ICG tracheobronchial fluorescence I was talking about, and that node, what we do is go straight onto it and then separate it initially itself so that when you come ventrally, it becomes very easy to drop it down. So the apex of the carina, I think, is the most difficult area to clear. And if you do this maneuver, you're already there before you actually have done anything ventrally and before it actually bleeds there. Because bleeds here produce a discomfort for the surgeon. But before that happens, if this vessel is actually coagulated and cut, then the bleeding is much lesser. So it's just the reverse of the way most of us do this procedure, but it actually works well. And the uppermost node comes out along with it. You can see multiple small vagal fibers interspersed with the vessel. In a middle third cancer, which is bulky, I would not bother to preserve this vessel. But in a lower third, I think it's always worth doing this and clearing the whole disease, but keeping what needs to be retained. Keep continuing like that, and then keep chipping slowly around the vessel. and then there is a small node here, and there is a small vessel which is actually branching out and entering into the bronchus here. So it's dividing and entering into the bronchus.
So in patients of middle third, where there are bulky tumors, in case
Yes.
you want retraction, how do you go about it? Do you put an additional port?
No, yes, I actually use a extra port for practically everybody, Karthika. While we do the supracorneal dissection, I'll always have an extra port. I'll show you that. I'll not show you the port, but I'll show how it's actually used. It's a dorsal port.
Yeah.
It's midway between the postaxillary line and the spine.
Spine, got it.
It works very well because suprazegas portion laparoscopically is 10 times more difficult than in robotics. But if you add a port, it becomes much easier.
So we are slowly moving towards to semi-prone, but
We should, because see, I've done both in Asian Institute of Gastroenterology and in the MNJ Cancer Hospital where I used to work then. After some 6 years of prone position, I shifted to semi-prone, and the first procedure itself, I felt it much more comfortable. We had done lateral also initially. Lateral was probably the most uncomfortable. You have a vessel there, and I didn't want to use a energy tool here, so I took a chance with vessel that is getting into the node. But at this time also, although it was bleeding, we have never held the vessel, because if you hold the vessel, it will undergo spasm. And while I was dissecting, I thought that this vessel may or may not work, but you can see how it is actually bleeding. So there is all the burst pressure in the vessel. Without holding it, while shifting the suction into the left side, sucking continuously, I slipped the clip. We could have done better by clipping it before we cut, but Samir told me it should be loosely edited, and whatever small problems we see on the table have to be shown to the younger ones. So there's absolutely nothing to hide, and these things keep happening. A small error of judgment, and it bleeds significantly and makes the whole field red. And there was a tendency to coagulate, but once again, I thought it'll actually extend the burn onto the artery. So refrain from that. Went from the other side and teased it down and did a cold cut.
So must appreciate extremely delicate dissection. Till the moment we realized the bleeding, we thought it's a vessel which is already been coagulated. There is no flow inside.
What I would really want to convince younger people is when we started
Beautiful, sir.
preserving these vessels,
Sir.
we all had such doubts. Can you see that?
Yeah.
It's feeling almost like aorta.
Yes.
And perfusing and arborizing this place.
Very nice, sir.
How
Very
well
nice.
it is arborizing all the vessels there. So it actually works. It actually works. And for decades, we have neglected the left bronchials. Sometime in Amasi, I'll speak about left bronchial for about 15-20 minutes, showing the various patterns of left bronchials. We keep talking about right bronchial and preservation, but left bronchials are neglected, and sometimes left bronchials are much bigger than the right bronchials. So shifting to the upper side, there's a bit of change of ergonomics here. I've actually put the port, the dorsal port, and moved from the mid-axillary trocar, as far as my right hand instrument is, into the 12 mm tip of the scapula trocar for a while, and then later on I change to the mid-axillary line trocar while the post-axillary line trocar does the retraction.
Yes, absolutely. And so with respect to airway, you are using ICG routinely, but for all the surgeons out there, while dissecting around the carina, we have to be very careful of the bulb. It many a times mimics a bronchial node.
Absolutely. And we had an injury, Karthik here. Karthik and Sandeep, we had an injury just because of that.
Yes, yes.
It just happened to my one of my colleagues, but if I was there, I also would have had a similar problem. So it was like that. So it can be a real masquerader. You have to be very, very careful. Yes.
Yeah.
There are nodes close to the right bronchial. If there is a right bronchial, this patient does not have a right bronchial. So those nodes have to be cleared. And then these are the nodes which are missed because, especially if you are preserving the azygous vein. And I make it a point to preserve the azygous vein because it's good to universalize the procedure. If you have sacrificed the azygous vein, you have directly sacrificed the right bronchial artery. So right bronchial artery rarely would ever survive unless you separate it, and which is not an easy job at all. So you can actually see the interface with the tracheobronchial fluorescence. Makes it much more easier in salvage procedures. This is a simple procedure, so it may not actually be a matter of great concern. But in a salvage procedure, the color of the trachea, the color of the esophagus, because the esophagus from pink becomes blue in white in color, so it becomes much more difficult to do this dissection.
Yes, absolutely. This interface is very thin, and we have very less error of margin here.
Yeah, it's very good to use it, especially after radiation therapy, and especially if you are doing salvage resections after more than 50 gray, 50 or more, and that is a thoracic duct that we have injected. So it stays green for about 5 to 6 hours that we have seen. In sometimes salvage esophagotomies, it takes 3-4 hours to keep on chipping and chiseling and getting it out, and the thoracic duct retains the dye for so long. Yeah.
Rao sir, even in purely middle third tumors, you preserve the azygous vein, or you?
No, not always. See, my preservation of azygous vein is if it is very close or if it is involving, I won't preserve. But otherwise, even in middle third, just because it is removable, you tend to remove the azygous vein. And there are many other structures which are also close to the esophagus, and you don't remove them. So if it is close to the very close to the tumor or involving the tumor, I remove. Otherwise, I don't. Even in middle third, we preserve, and it is possible to preserve. Only thing is, you must make a steady attempt, and this part of it, we need to stress the fact that we keep on looking at the recurrent laryngeal now only. But what I would stress is there are at least 4 tweaks that the bronchial that the vagus gives posteriorly along the trachea.
Yeah.
Your endpoint here in the right paratracheal dissection is not the trachea, but it is the number of leash of nerves that actually come down, and there is always a node, a large node below the inferior thyroid vein while you are dissecting for the recurrent laryngeal nerve. So, and this node should be removed, and this is the only node generally we send it for frozen section. If in case you can actually see the number of nerves running down the trachea, if these are preserved, the bronchociliary movement of the tracheobronchial tree postoperatively is generally much better maintained, and that is the reason why these patients do not develop pulmonary problems. Pulmonary problems are not because you injure the trachea or produce ischemic damage. It's because you lose nerve supply to the trachea. And initial few postoperative days, it's important because the secretions are cleared in an anti-gravity fashion. So for which you need cilia of the respiratory tract. So for which you preserve both the bronchial arteries and especially the nerves, the vagus nerves that supply the tracheobronchial tree, and for which you need to put in a little more effort. And in high volume centers, high volume surgeons, this becomes easy. That is the left recurrent laryngeal nerve. This is what is called the suspension technique. I've always thought that the suspension technique is much easier, and as soon as you go in bulky nodes there medial to the nerve, unlike the right recurrent laryngeal nerve, what you often see is on the left side there are nodes between the nerve and the trachea, which need to be cleared. Ergonomically, it's not the easiest of the things. this part is much easily done in robotic. So, and with just 2 or 3 instruments, this can be much more easily done. So that is the suspension technique. And Karthik was asking me, for this, we use the fifth procar.
Yes.
And it's also important to clear the AP window.
Sir, what is your routine extent of lymphadenectomy? Do you do this complete clearance in all tumors?
All squamous, yes. All squamous.
Okay. So
All
at our center, we perform only a standard 2-field. And
Okay.
we're doing a total mediastinectomy only if there is a tumor that is at the level of carina or going above the level of carina.
Okay. No, but we do it for all squamous, and we separate the nodes on the table itself because it's much more difficult to identify which node is what.
Yes.
And right paratracheal, Karthik, is actually a danger zone. On the left side, they are less common. In AP window, they are less common. In a lower third, AP window, you find positive nodes much less commonly, but in right paratracheal nodes are common. So once we analyze the first few patients, we wanted to clear the right paratracheal and then ended up doing a complete extended lymphadenectomy, extended 2-field lymphadenectomy for all patients. So that is the pulmonary vein, that is the AP window. Once again, it's you can use multiple tricks to do this traction and multiple retraction techniques. That's not a part of this talk, but how you retract and how many instruments you use itself is a talk on its own. The next part is the abdomen. These are the 5 ports we use. We use anestheticians these days. We used to use a gauze piece mounted on a grasper previously, but we want the assistants to relax while this procedure happens. And it's a 5 mm hole that is made. We don't use a trocar. We just push the anestheticians directly into the abdomen. So it works well. It stays, and it's self-retaining, and it stays for a long time. Although it's always good to release it on and off because there can be significant liver congestion, and there are studies to suggest that there can be liver atrophy in patients who have this retractor for more than an hour.
Doctor, you are standing in between the legs of the...
Always, yes. Except this a small part of the procedure.
Okay.
Always fit leg position.
So, Dr. Sandeep, how do you go about? You also stand between the legs of
Yeah, standing between the legs for, yes, even gastrectomies and for this esophageal
Yeah, the Japanese do it from the right side.
So do we.
Oh, really? Yeah.
Sir, I remember you talking about that you are a ligashore man.
Yeah.
But we are seeing extremely magical steps with harmonic as well.
I don't use it too often. This is a much older video actually. So, but harmonic is a great tool. Absolutely,
agree, sir.
No doubt about it.
So, Dr. Sandeep, how do you suspend the liver? Because we have got a lot of innovative ideas from surgical gastroenterologists and laparoscopic surgeons.
Yes, sir. What we do is we use a bowel holder. Yes, sometimes you feel liver is really fatty. You use a gauze piece along with that. Otherwise, even a needle holder, what Professor Palanvelu used to do, I have been trained with sir, so we have the same technique for retraction.
No, Japanese push a needle through and then put a bolster and lift it up. Is it not? They pierce the liver, come out, and then go out and do it. There are multiple techniques.
Yes, sir.
Agree. Yes, sir.
If you don't want a port to be wasted, I think that's not a bad technique, but it's too invasive for liver retraction, is it not? Piercing in the left lobe of the liver and going out, I don't know. I was not too convinced about it.
Agree.
Yeah, one of my colleagues in the institute does that, but somehow there is some trauma inside, although it may be trauma of no consequence, but I think it's good not to do it. But with netizens, once you remove it, the whole liver is really congested. That does happen. It has its own grade of injury, which is blunt injury when compared to the needle, which is sharp injury. So once you hold some tissue for long, it gets ischemic for a while. Somebody has done CT scans of the livers after gastrectomies, after prolonged retraction, and they have understood that about 10% of them undergo atrophy, left lobe atrophy. They have compared pre-op and post-op, so it's surprising.
We even have noted asymptomatic elevation of liver enzymes whenever we use self-retaining laparoscopic retractor.
You have done a study, good, which is an indicator of at least transient liver injury, isn't it?
Yeah.
But here they are talking about permanent injury, actually,
Okay.
which is much more worrisome, is it not? But we continue to use it the same way, although there is literature, just one paper, but it is significant. There are pictures of the CT scans, pre-procedure and post-procedure. It's quite convincing, actually. Probably it's good to release it sometime in between. You complete one step of the procedure, you're doing the splenic nodes now, and then you come back, release it for a while, and then continue it. Maybe, yes, it should work that way.
So in elderly, I think we should be much more cautious because they're going to have a splenic hump coming up. So we stick close to the stomach whenever we are dividing the short gastric at the level of splenic.
I think that's a very good instruction, because what happens, especially the ascending splenic vessel, gets injured, and then you have a upper polar infarct, which is very common.
Yeah.
So it's important to be very close to the stomach, because more often than not, that part of the stomach is sacrificed anyway in the anastomosis. So it's good to be closer to the stomach than to the other side. So and then you go on to the hiatus. This can be done in multiple ways. You can start from the hepatic artery. Hepatic artery is the most important vessel of the three branches. So you do that first. That is the most difficult, because especially if you have a pancreas that is projecting up, hepatic artery is the most difficult. So these days I actually do it first, because if I've got that out and completed the 8A and 8P, then it becomes very easy. This part, Karthik and Sandeep, is much more easily done if you stay on the right side of the patient, like what the Japanese do.
I was just about to
say that, is it not? So I've always found this part much more difficult between in the split leg position of the patient.
So when we are at the right side, sir, we have the assistant with the bowel grasper who is rolling the pancreas down. So he brings the entire thing in front of us. And,
absolutely, and we are working parallel to the vessel, is it not?
Yeah.
Makes a lot of sense. I keep telling the young people to do that, because you keep learning, and at every stage there is a better method. That is the vein. Vein generally goes a little more laterally, but it can join any part of the portal vein or the splenic vein. Sometimes there can be two vessels, one going into the splenic vein and one going into the portal vein. So you must isolate it and clip it.
I think we have Professor Palanvelu sir also online. So I would like to say anything, sir.
No, go ahead. I don't want to disturb. So, Sunil, I'm enjoying you. Just go ahead, and our people are interacting, and very nice.
So good evening, sir.
Good evening to all.
Pranams to you for teaching us and convincing us about minimal access. So that was the most important challenge during the 90s and the last decade, last two decades, convincing people that minimal access is safe. It took some time, but I think all the efforts are bearing fruit. It's all minimal access now. Anybody who is not into minimal access is considered as an outcast. So, largely due to your efforts and many other friends also who followed you, and they were steadfast in holding on to onto what you believed.
I'm enjoying your surgery. Clarity is so nice. It is coming.
Thank you so much, sir.
And I think I can continue to talking. That I will.
Thank you, sir. Thank you so much.
Yeah,
Your blessings. That is the left gastric.
So there is a 15 to 20% chance that we are going to have an accessory or a replaced.
We see that. I will show you that here. It's about 20% of the times, 20 to 25 actually, correct. Many times about 5-6% it's a small vessel, but many times it's significant. That's something that you must watch initially itself, and you can make out this patient did not have it.
Yeah, mostly it's a preoperative diagnosis. We go in prepared whenever.
Very true. It's preoperative and intraoperative also. First thing you must do is to go there and see if that vessel is there in the lesser omentum. Yes. Before you make any cut, because if you start cutting and then you chop the vessel, after that whatever you do on the left gastric it would be futile.
So, what would be your extent of lymphadenectomy on right side of the patient, especially?
It's the medial, the left side of the portal vein. Yeah, we don't do a lymphadenectomy in front of the hepatic arteries and things like that. So,
sure.
Considered as enough, yes. Yeah.
Enough, yeah. Agreed, sir.
And because you asked that, I think in esophageectomies across the world, when you see the videos, all the stress is on the mediastinal lymphadenectomy, while this part of the lymphadenectomy is actually neglected. While the stomach surgeons, there are stomach and esophageal surgeons. Stomach surgeons who are separate, especially in the East, do a very, very meticulous lymphadenectomy of the abdomen. So you call it two-field lymphadenectomy, but the abdominal clearance is not generally as good as the thoracic clearance. So there's a lot of hype and a lot of importance given to the mediastinal clearance. But when you come into the abdomen, because it is during the later part of the procedure, probably the abdominal lymphadenectomy is quite often neglected. That is something that I always thought Palani sir and all of you can comment on that. But I think it's important to do a good lymphadenectomy, even in a esophageal cancer, even if you have a middle third esophageal cancer. It could be squamous cell carcinoma also, because studies show that these nodes can be positive.
I think I do agree, sir. The comfort level for surgeons who are doing routine gastrectomies, or especially pancreaticobiliary surgeons who are doing Whipple's and biliary sections, they are more comfortable to handle HDL. Somebody who is more dedicated for a esophageal surgery or thoracic surgery, they feel it is not an area of routine comfort for them. So possibly the extent of
very
might
true.
vary. Yes.
Actually, that is the correct word. So once you are less comfortable, it becomes less invasive, is it not? The procedure becomes less invasive.
Sure.
This part is being done from the left side of the patient. I've moved to the left side of the patient.
So the advantage of radiation-induced edema in chest was very clearly evident, which is not the case in abdomen.
I didn't think about it, but it's correct. I think your observation is correct. I actually never thought about it. Yes. And then I think this is probably very important. It's good to start beyond the third or fourth arcuate, not start very close to the right side, because beyond that the momentum even in an obese patient is on heel like, and you easily reach the third and fourth layers of the momentum. And it's good to use an instrument like harmonic because it shears and opens it, at least for this part. And then you go upwards more than downwards, especially if you are a learner. If you are an expert, it doesn't really matter, because what is important for the stomach to stay vascular is the horizontal component of the epiploid. Even if you lose a part of the vertical component, most of the stomach remains vascular. So, if you're not the best of the minimal access surgeons, I think close to the root of the hand, this flip really helps. Hold the dorsum of the stomach and flip it upwards, and that's when everything stays safe. The whole thing is lifted up, and you can choose where to actually cut. That is the left gastroepiploid, and then you know where the colon is. So a dorsal hold and flip of the stomach, while the pedicle goes onto the anterior aspect of the stomach, is something that works well. And if the assistant is holding on to it, rest of the procedure can be done very, very easily.
So I want all the audience here to note. So if you had seen initially, you had the assistant port holding the body of stomach, nowhere anywhere close to the greater curvature. And if you see Sir's left hand, it was just retracting and not holding the fat close to the pedicle.
Anything at all, yes.
Yes, even the traction there can cause significant hematoma, which all thoracic surgeons, it's a nightmare for us.
This part, if you are planning a hybrid procedure that I wanted to show, we keep doing the total laparoscopic also, but we just wanted to show one video. Samir told me one full video, which is loosely edited for 50-60 minutes. So this part could be done in when you open, because from a small opening, the stomach tube that can be delivered out if you have completed the neck part. So this part can be very easily done, very nicely done through a very, very small incision. So it should not be hours to open at this stage, or leave this for the open component when you are learning, because any injury here can become very, very disastrous.
So what is the distal extensor? Till which point do you routinely cockerize the stomach, or
we go up to the middle colic and stomach cockerization? You mean minimal cockerization in every patient? Minimal means actually we lyse the adhesions between the gallbladder and the duodenum. We don't cockerize regularly.
Yeah, that is the point where we really stop.
Yeah, correct. Here again, we don't do it completely, and it's practically never necessary, but it is necessary in one clinical situation, which is not very common for the GA surgeons, but it's not uncommon for the oncology friends, while you do a laryngopharyngo esophagectomy, because you need a much longer stomach to anastomose to the base tongue. So in laryngopharyngeal esophagectomy, we do a complete cockerization and then mobilize everything.
Rao sir, I slightly want to disagree with you regarding the mobilization with the small open incision, but this amount of comfort and completeness of mobilization, I think laparoscopy stands ahead.
Wonderful. No, basically, I have all of us have lots of trainees undergoing training. An injury there can be very dangerous. So I allow the experts to do that, but not the trainees, Prakash and Sandesh. That's how it is, and the G junction is tied. We do it through a horizontal incision. I cut the medial end of the sternomastoid for access. Not only for access, whenever we do an extended lymphadenectomy, what I've understood is, if you keep this space open, even if there is a leak, there is a chance that it doesn't seep into the mediastinum, and because this is an open space, it comes out rather than going inside, because the muscle can stop the secretions from coming out into the neck wound, and it might get into the mediastinum. So the medial end of the sternomastoid is something that we cut on a routine basis, and we don't suture it back. Gives you much more space for anastomosis, staple anastomosis that I'm going to show you, because once you staple, it's a rhomboid anastomosis. The anastomosis the esophagus and the stomach need a little more space in the neck. This is what I was trying to tell you. This part can be done through a small incision. Ensure safety of the pedicle at least. If you can do it minimal access, it's always wonderful.
And the mobilization part, if the audience has noted, I think the thoracic mobilization helped us in looping the esophagus easily in the neck. The more we mobilize well in the thorax, just up to the root of the neck, the chance of injuring the nerve becomes very, very less.
No, but how do you do that when you do a two-field lymphadenectomy and without an extended mediastinal dissection? Okay.
So we stick to the esophagus, sir. We go beyond and beyond.
Okay. So under the azygos, subesophagus close to esophagus, you dissect completely.
Yes. No, we.
That's what I also do. I also use because now we do mostly extended two-field. So while we were doing the subcarinal dissection only, that's what we used to do. Under the azygos, you keep dissecting upwards and completing the esophageal mobilization without doing the supracarinal lymphadenectomy.
Yes.
Yeah. Works well. Because any blood dissection from the neck can still be very dangerous, especially for the blood vessels and the bronchial tree, the tracheobronchial tree. So a finger that goes in can injure anything. So it's good to mobilize always. Once you have done a thoracoscopy, mobilize the entire esophagus so that the neck part becomes easy. And pushing a blunt finger from the neck is not something that should be done these days.
Yes.
It's a technique of the past.
So you routinely use 2 layers or 3 layers here, sir? Any preference for you in making the conduit, and how wide do you make it?
Layers means staplers?
Yeah, staplers. Two rows or 3 rows? Staplers?
No, so 2 layer stapling at all in the operation room. We have stopped using 2 layers.
Yes, we have also moved for the last 3 years.
I don't know. It will go out of supply, Prakash.
Yeah.
It's not long far away that it will go out of supply because all endostaplers are 3 layers now.
Yes.
Only the open stapler I'm just checking for the bleeding there. Yeah. I've left a little bit so that you can suture and pull it up.
Do you routinely use again ICG here, sir, for
everywhere? Yes, ICG everywhere. That's what we're going to show you. And we measure the arcade length as a part of a study, where it is actually ending, and then the dependent length of the conduit, the diameter of the conduit, everything is measured under the spy camera. The dependent length is also measured. And then it's important to keep the pressure up because while you inject any perfusion study, it's important to see that the BP is good.
Sir, with this perfusion, do you change your level of anastomosis, or it's just a reinforcement?
Quite a few times. Actually, I was shocked by the perfusion study for some 5 days back. It just stopped short, and then we had to go back into the abdomen, open the abdomen, and do a complete cockroachization because we were just not happy. At 90 seconds also, Prakash, it was falling short. We pulled the stomach up and did the ICG again in the neck, and it was not looking good. So I pulled it down, did a much more mobilization of the pedicle, mobilized it completely from the colon, the hepatic flexor I dropped, then mobilized the pancreas and the duodenum up to the midline. And that is when I got a good stapled anastomosis in the neck. So it actually helps. Although for an experienced eye, I think you can make out that there is some problem with this conduit. That the real pinkness, if it is not there, I think you should be wary because it's important to do everything. You can actually see that the incision is very small. And some part of the procedure, the gastric tube mobilization, I've done it open. So it's something that can be done well. And while you do this, we open a full tube of jelly onto the stomach tube so that it goes up freely. And while it goes up, I think it's important to maintain traction on the thread so that it doesn't twist at any point of time. Tight traction is important. You may put a NG tube, you may put a sleeve or anything like that, but what is important is to maintain traction, because if the stomach is lying loose, that's when it can actually twist partially and produce problems. And that would be one of the worst complications that you would ever see.
So this part of taking up the gastric conduit is something which everybody is slightly worrisome that.
Yeah, correct.
Yeah, we don't want any pull.
Yeah, we use the endostapler these days.
Yeah.
But this also works well.
So at this point of time, now recently we have started putting the feeding tube, sir. Once the posterior layer of anastomosis is done, we put a feeding tube into beyond the D3. We won't push it into the jejunum and leave it at the D3.
How would you do that into the D3 now? Because
once
I don't know, abdomen is opening is very small.
Yeah.
That is the anastomosis, and that is that video. And then if you want, I'll show you a small clip. Sorry. A small clip of no, because not always situations are like this. We have done about 34 salvage esophageectomies in the past 10 years, and it can be like this. 60 gray given, young patient. While we went in, nothing was seen. So we activated the tracheobronchial fluorescence and then started chipping in. Patient was fighting fit. So we understood the bronchus is here. So stayed under the bronchus. And then, so what is important is most of the fibrosis, significant part of the fibrosis is actually limited to the pleura. Once you cut the pleura, understand anatomy and cut the pleura, rest of it actually listens to you. Although there is denseness, you can actually see the ligature playing there.
We can see your instrument much more cautious in this surgery.
Yeah, than the other one, yes. Because any mistake here, Prakash, heavily irradiated and load so much of fibrosis, it can really produce problems. So I was not very comfortable with the plane there. So we opened a plane where the fibrosis is a little lesser. You can see how well the tracheobronchial fluorescence helps you. Otherwise, the esophagus looks white in color. The membranous trachea also looks white in color.
Even the aorta is white in color. So
everything is white in color. So you add a little bit of color to one of these organs, then it becomes much easier. It doesn't open easily at all. There's a lot of force that is being used. So this is where I've cut the azygos here. Cut and removed a piece of the azygos, in fact. And then we proceeded. Went on chipping, and that is the bronchus. That is the trachea. Once again, keep on chipping slowly, and it just opens up. And we have seen this in innumerable number of patients. Only appeal, why I'm showing this video is, do not give up on these patients. I'll tell you why we should not give up on these patients while the video is coming to an end. And just see what is happening there. Dense fibrosis there. On the other side, the greenness of the trachea is seen. So in the white light, you don't know whether this is the bronchus or whether this is the bronchus or the esophagus. But once you activate the fluorescence, you know it is a part of the periesophageal tissue. So I used a sharp tool, a shearing tool. The best instrument is a monopolar. Only problem is it fogs and it has less control. if you are not well trained. So it just came off the carena, and then this procedure took about 4 hours for me in the thorax itself, and then the whole procedure took about 7 hours. But the patient recovered remarkably well, and this esophagus showed no residual tumor. And even at this stage, the left bronchial artery could be saved, because it is something that is on the other side of the bronchus, and it could actually be saved. So you can actually see that complete carinal dissection, paratracheal dissection has been done. So it's good to help these patients by dissecting them. The other small challenge that you see in about some 6 patients that we have seen is a CT scan like this, wherein you have an abnormal right subclavian artery arising from the aorta. It's dangerous because of two reasons. One is it occupies the limited space while you're dissecting the left atrial angel now. That is abnormal right subclavian artery, so which is behind the trachea, coming out from here, and that is the left atrial angel now. Makes this not difficult. The instrument is actually pushing the subclavian artery. If it's a definite trap for the unwary, because innumerable number of limb losses and deaths have been reported because the surgeon was not aware of this. You go inside like any other procedure and then keep cutting around the esophagus, you'll get into this vessel, which can be a dangerous an anatomical anomaly in this procedure. And what is also important is, in these patients, please remember that there will be no recurrent angel now. The anatomical anomaly is accompanied by non-recurrent laryngeal nerve. So right recurrent laryngeal nerve is always absent when you have a abnormal right subclavian artery. A complete clearance could be done through this window. But what we have done in this patient is, we staple the esophagus here and pull the esophagus down so that we find some space there. That is the end of my talk. Sandeep, Prakash, Samir, Palni sir, I don't know if he is around. Thank you very much. Kalpesh, thanks from the bottom of my heart. Thank you very much for remembering me.
Thank you, sir. It's always been a pleasure, and
we should be thanking you. It was a great learning experience. Even I picked up a lot of things from all this video, and we hope to have more and more of such great masterpieces videos from you. Probably next year we'll again arrange something on another organ, because we have a lot to learn from all our seniors here, and I feel that we have not been utilizing all these opportunities to learn now, because of the availability of this digital media. It's become much easier, that the transfer of knowledge and the learning process has become much easier, and we should be exploiting that. And probably plan to expand this program a bit more, and we hope that sir will continue. I'm sure he will continue. I'm sure he will be there to teach us and educate us. Thank you so much, sir. Thank you so much.
Thank you very much.
Samir, you want to add anything before you wind up?
Yeah, sir, I think it was amazing. Very fine points. We have no exposure for ICG, but I think it would be a learning point for us to know each and every small bit, because it will add to safety of patient. Good discussion generated by moderators. Actually, this is what I wanted, that one thoracic and one GI, the approaches may be different, but a master can actually give small points to everyone. Sir, thank you for being there.
Samir, what I would humbly submit is, I didn't want to tell that during the presentation, but this tracheobronchial fluorescence is something that actually originated from our institute. We did the first human study, and it has been published for the first time in diseases of esophagus. Nobody has actually used it, and this happened because of a problem that I had on the table. There was a salvage esophagectomy, and it was after 1 hour, I could not really understand the interface between the bronchus and the trachea. I mean, trachea and the esophagus. So I actually descrubbed and told my colleague Sarjan Shukla, we have been using so much of ICG, and there are people who are using it in urinary bladder also. Why would it not work through the membranous trachea? He said, why don't we instill? We thought. He said, sir, instead of instilling, why can't it be nebulized? Because the anesthetic was unhappy with fluid going in. So we nebulized, and we were really amazed at the ease with which this procedure could be done. So these things happen. Adversity is the mother of invention. It's not necessity anymore. In adverse situations, I think such things happen, and this is the first ever publication. I'm very
Sir,
proud.
but I accept that that is so, but I think only masters can pick up that point and gain something so that everybody should gain. So basically, patient benefits. So I think everybody may not understand small point, but this is what. So the entire program is designed so that I think the new generation should adapt some new things, and whatever said, they should get on with doing any case safely with a better technique, better modality, the using of all these gadgets. I think chief had also logged in. He's still there. Sir,
Sir
you
is
want
still
to add, sir?
there? Sir is still there?
Yeah.
Yeah, he's there, sir.
I enjoyed the surgery, very nice and discussed. And I don't know, I want to trachea bronchial tree, Subhaneeshwar done the largest work, very nice. What happened to thoracic duct? Do you use ICG or don't do use?
ICG always, sir. The thoracic duct was something that we have been doing for a very long time, but always, sir, always.
Yeah.
Yes, sir.
But I
So,
saw the gastric tube,
Sir.
and outside making it is my 130 cases publication only through mini incision, like what you shown today.
Sir.
And but you first stapler you are making across, then you are going vertically by the side
Yes,
of the
sir.
greater curvature. I found here this is
Yes, sir.
goes with little narrowing, but if you go obliquely cut at the lesser curvature using golden cartridge, then going 5 to 6 centimeter minimum, going to up to fundus, and as you shown the ICG, the tip of the stomach little less vascular. No, you just
Sir,
identify the. You can avoid that one. No.
I'm glad you brought that up, sir. We actually changed into that. I told them it's an older video. Thank you very much
Okay.
for saying that.
Yeah. No, it is.
I've seen you do that, and we have changed into a straight cut now.
Yeah,
Yes.
very.
Yes.
But otherwise, technical tips you have shown today, very nice.
Thank
Very
you so much.
happy the way. And I've seen Japanese dissecting from standing right side. I
Correct.
always do between the legs. Today I
Yes.
saw the way you use instrument from the left side. Wonderful nodal clearance of surrounding the common hepatic artery and close to the bile duct. Very nice.
Thank you.
And the instrumentation, people have to learn the way used today. I think it is very nice going, parallel to the instrument, very nice plane. And that is where the advantage of laparoscopic surgery, and we got it now.
so I think thank you, chief. Thank you, Subramanian Rao, sir. Thank you, moderators. I think before we end, Pashupati, can you put up a presentation of forthcoming events? So the mega event which we are awaiting at Jaipur from 28th of August to 31st, that is Amasicon. I think you will see Dr. Subramanian Rao also there performing live surgeries. Not only him, there will be further many stalwarts coming from India as well as international forum. So please register for this event. Next slide, please. Then, just like what we have Amasi lens, we have CME, which is held on Monday. This time, Dr. Borgaonkar, who is the president of Hernia Society of India, is going to speak on GERD, hiatus hernia, and the surgeon. Next slide. Then we have FMAS course, that is 116th, which will be from 4th to 5th of July. It will be at Jaipur. This will be preceding the conference. Next slide, please. Then 117th FMAS course will be at AIMS Guwahati. Next slide. So any people who want to register for FMAS, get their skills updated about laparoscopy, please register. And yes, please do not forget to register for Amasicon, which will be in August. The chief would be there. All stalwarts of laparoscopy would be there in Jaipur. So may I request Pashupati to put up the video of our event sponsored Merrill.
What was a visionary dream has now blossomed into the realization of a globally renowned medical device powerhouse. What evolved from a modest beginning now operate one of the most cutting-edge facilities in healthcare. What once was a single venture has now proliferated into a presence in 6 distinct domains. What began as a modest collection of products has flourished into a portfolio of over 200 diverse products. What was conceived in one country now operates through more than 150 nations. What started with a few inspired individuals has burgeoned into a global team of over 10,000 plus dedicated medtech professionals and underwent an evolution, experiencing substantial growth to emerge as a dedicated brand poised to address the healthcare needs of this world. All of this made possible through achieving comprehensive excellence in all domains. By embracing modern innovations that enable to win the hearts of healthcare providers and patients across the globe. The progressive transformation of the infrastructure has seamlessly mirrored the pace of technological advancements, culminating in an unparalleled achievement of elevated output and precision in production, setting an extraordinary standard within its niche. Welcome to Merrill Endosurgery, your one-stop surgical solution empowering excellence across oncology, bariatric, thoracic, gynecology, urology, gastroenterology with innovative and reliable instruments. From precision cutting tools to advanced energy devices, we deliver comprehensive solutions for modern surgical needs, ensuring safety, efficiency, and superior patient outcomes. Introducing Mirus, range of stapling products. Powered endoscopic linear cutter. Endoscopic linear cutter. Linear stapler. Linear cutter. Circular stapler. Hemorrhoid stapler. Monic trocars. Eliaro trocars. Eliaro bladeless trocars. Introducing Merrill Hernia Portfolio. ITAC A. Apsimesh. Merigro mesh. Philiprop mesh. Philiprop mesh soft. Marinium mesh. Profound N. Profound A. Mesic energy device. Mesic compact ultrasonic. Mesic laser. Mesic ultrasonic. At Merrill, we don't just innovate, we empower. Together, let's create more to life.
So I think I should thank everyone. Then I think we should end this session. Sandeep, Karthik, you want to say anything?
Yeah, all things have been done. Thanks to Amasi,
Thank you very much.
and Subramanieshwar Rao sir for the wonderful
Yeah,
session.
I think Subramanian Rao sir, he was not well. He was still coughing, but the passion to teach and teach his technique, propagate knowledge. I think salute to him, sir. So thank you, sir, for giving us time. Though it was postponed for reasons, but finally we could achieve. Maybe we'll come back to you again for another organ, as Jani sir told.
I
Uh,
don't know. Kalpesh and Samir, last time I had a renal colic and I was
yes, sir.
very,
Yes, sir. Yes, sir. We know that, sir.
very
So
sick. And 4 days back, I was very sick. So this time I was telling my wife, I just don't want to give excuses to these two gentlemen and Palni sir.
so
I just
thank
don't
you, sir.
want. I don't want to be apologetic. So I was just praying that I'll be fit to talk, and I've done that. Thank you very much.
Sir, thank you, sir. It is your passion to do it and commitment. So we really appreciate that. We'll be very happy to host you at Amasi concert.
Thank
Please,
you so
please
much.
do come.
Yes.
So thank you everyone. At the we end here so that we'll meet again in Amasi online series on Monday, first Monday of July, and we'll bring another Amasi lens on third Thursday of July. Please log in again and register for AmasiCon also. Thank you everyone.
Thank you. Thanks a lot. Good day.
Good night.